Hello, friends. A very good day to all of you out there, and a very, very warm welcome from the entire team of RFA Tutors. You're mentor this side. I hope everybody is doing great. Thank you so much for joining in. Every single thing that is taught today should be part of your neurons. If not 100%, at least 70% retention should be there. When we talk about HMB, guys, the heavy menstrual bleed is at least one extended match question in your exam with 3 to 5 questions, which is a very, very strong part in your Gynec exam. Moreover, in Dhumati, you may get 3 single best answers in addition. You know why? Because heavy menstrual bleed is lots and lots of differentials. This is strategy 2025, guys, which says that heavy menstrual bleed is defined as excessive menstrual blood loss leading to interference with the physical, emotional, social, and material quality of life of a woman. The first and the foremost thing in the question, no matter its EMQ, no matter its single best answer, is taking a thorough history. Now, the first thing you're going to see for the single best answer is that does she have a regular cycle or irregular cycle? And if she has irregular cycle, does she have intermenstrual bleed? Does she have pelvic pain? Does she have pressure symptoms? Why? Why am I going to see that as a candidate? Because if there is intermenstrual bleed, I would think about something which is locally affecting the cavity. Yes or no? Right? My DD would be something else in extended match question. If she has a pelvic pain, I am thinking about some mass sitting out there. Something is wrong with the cavity in alpha. Yes? Or if in exam question they say she has heavy bleeding with pressure symptoms, definitely yes, I am more towards the differential of fibroid. Do you guys understand? EMQ comes with hints and you have to pick those hints up. They would give you a direction because if your diagnosis is not correct, unfortunately, the management goes wrong. Right? So heavy menstrual bleed would affect our quality of life, but HMB associated symptoms you're going to find out. So when you read HMB question, your vision should be okay. With HMB, what does she have? Does she have pain? Okay, it's painless. My differentials are separate. Does she have regular or is she bleeding in between the periods? Is she bleeding after sex? Does she have pressure symptoms? Does she feel any sort of a heavy bleeding? What is the examination given with that? What are the examination findings then? So the first step is history. And after history, you have a very, very clear role of examination. But remember, they clearly say that if at all any patient's history does not go towards local causes or mass, or we are giving tablets. I repeat, listen to me very carefully, ladies and gentlemen. It's the first EMQ of your exam, please. She has HMB, no related symptoms. When NICE guidelines says no related symptoms, they mean no IMB, no pressure, no pain. It's only that she says now I am using more sanitary napkins, no more pads now, which I used to use earlier. And there's no hint towards any local or physical cause then. In exam, without examination, you can start pharmacological treatment direct. They would give you an exam fibroid less than 3 centimeter or adenomyosis. What would be the first line treatment? Quickly, guys. Less than 3 centimeter. They ask you first line treatment. What would be the answer? Very well done. Now she declines. She doesn't agree with, or it is not suitable for her. Very good. We have non-hormonal treatment. tranexamic acid, NSAID. We will choose non-hormonal treatment if she has fertility desire in exam. And if she doesn't have fertility desire, she doesn't want fertility, we will choose combined hormonal contraceptive pills. Do you guys agree? So this would be first, this would be second, and this would be third. Am I clear about the sequence of treatment, please? Ma'am, if we have to choose between tranexamic acid and NSAID, please pay attention here. Tranexamic acid is the first one for HMB. NSAID is the first one with HMB plus dysmenorrhea. Painful periods. When it is painful periods, NSAID is the first one. When it's only heavy bleeding, tranexamic acid is the first one. Does it make sense? Everybody with me so far? This extended match question in front of you is clear, yes or no? This sequence of EMQ is clear? Yes, I'm just elaborating the same flowchart of strategy, but in my own stepwise way. Yes, you guys are with me? Okay, now. Now, Apurva, they say that the treatment is unsuccessful. Or Muntaha, they say that declines pharmacological treatment or severe symptoms. Right? Then we do investigations for the diagnosis. We can't go with the pharmacology. Why? Because initially, guys, we did not do the investigations. Because for a straightforward HMB, we can do directly treatment. Do you guys remember this? Do you guys remember this? All of you, do you guys remember this? So, if it is unsuccessful or if it is declining the pharmacological treatment, we would do investigation for diagnosis. And for this investigation of diagnosis, please remember we would do all those series which we have done earlier, or as a second line, we would do the surgical management, please. The question comes from classification and the type of the premenstrual syndrome. You have to understand that patient has PMS symptoms and we do the record of the patient. We have the premenstrual syndrome in different steps. Number one, you have to understand that wherever M is given means that she is menstruating. Okay? So this means these M block means that she is having periods. Any patient who is having symptoms before the periods, that means that she has PMS. Right? Please see here, this patient has symptoms cyclical and gets relieved by menstruation. Then she has a symptom-free week, no effect on the quality of life. She has her regular periods, no additional factors. This side, this one in the block, this side in the block, this one is severity of symptoms. That is y-axis. Okay? The x-axis is the menstrual cycle. Okay? Now I will tell you what do I mean by that. If you guys see here, the symptoms are from here till here. The symptoms are in the middle, half of the block. This is the whole block. It is here in the middle. Goes down on periods, stay normal. In ovulation time, again goes up and on periods come down. But they stay in severity just here in the middle. That means physiological mild PMS is happening and she just needs counseling. Every single lady comes to know that I'm about to have periods, how? You start being a little irritated, slight bloatedness, but does not mean that it starts affecting quality of life and we start having, off from work. Do you guys agree? So, if such a graph comes up in which the symptoms are there and they are in the middle of the severity, from it, they get better. And again, in the luteal phase, this is the luteal phase, this is the ovulation, this is luteal phase. And in the luteal phase again goes up, but stays in the middle. Its diagnosis would be mild PMS, which does not need any treatment. It would be just counseling and reassurance, which is normal for every patient. For every lady, slight discomfort before the periods is pretty natural. Now, comes the scenario where the patient has got symptoms which are going, I told you guys, this y-axis is severity. Going on the peak here, comes back to normal, again in the luteal phase, goes to the peak, gets back to normal. This graph is a typical graph of core PMS where we need to do the PMS treatment. Why? The symptoms are going on the peak as periods happen, decline, stay normal, go to the peak, again as a premenstrual, gets back to normal. So it is a typical PMS graph. Now let's see what's happening in the third, guys. Here, the patient, she has symptoms touching the peak. But what's happening? Is it going to normal? If it's a typical PMS, it should come back here, right? It should get back normal at M. At M means at periods, you should get back normal. It's not getting back. It's staying in the middle throughout the cycle. That means it's not touching the normal. However, before the periods going up, that means it is not PMS. However, it is some medical disorder which is getting exacerbated in the premenstrual phase. For example, some psychiatric condition, some mood disorders, epilepsy even, guys. She has a condition which is not getting back to normal because it's not PMS. Had it been PMS, it should touch the baseline. It gets worsened premenstrual. When it's not premenstrual phase, it stays there as a normal symptom of a condition. It gets worsened at PMS. Again, comes to the normal state, which is it stays, the symptoms stay there throughout the cycle. We say it is a condition where some medical problem which is getting exacerbated, in simple words, getting worsened as a premenstrual phase. Does it make sense? Does it make sense? Because it is not touching the normal, guys. Right? 1, 2, 3 is clear. I'll go to the fourth one, please. 1, 2, 3 is clear. I'll go to the fourth one, please. Very good. The fourth one is premenstrual symptoms. Premenstrual symptoms. But I can't see any M here, guys. I don't have any M. So, it is known as a variant where premenstrual disorder is happening, but absent menstruation. Very easy to understand. When this M in a circle is not there, which you can see here, see here, see here, that means it's absent menstruation, but very typical graph of premenstrual spike is there getting back to normal. Right? Okay. Now, number 5. Number 5 is M and P. This green written as like this is progesterone, which we just discussed the concept a little while earlier, which means that she is taking progesterone. So progesterone induced PMS getting back to normal, progesterone induced PMS getting back to normal. So this P P is typically known as progesterone-induced PMS, same as that of this one, but the difference is that here it is alone PMS in 2 and in 5 it is P given, that means it's progesterone-induced PMS. Now let's see the 6th one. The 6th one is not affecting by luteal phase at all. It is not a PMS because it has got nothing to do with the menstrual cycle. It has got nothing to do coming back, nothing to do going up. This is some underlying psychological disorder, please, which is not a premenstrual. Here we need to refer them to the psychiatric referral there. Okay, so in the situation where the patient, she has these variants, we treat the variant as it is. If it is mild PMS, just do counseling. If it's a core PMS, COCP and SSRI. If it's an exacerbation, treat the medical disorder. If it is absent menstruation, treat as core premenstrual syndrome, treat her with COCPs and SSRI. If it is progesterone induced, please give contraception alternative to progesterone. Don't give the progesterone. And if it is some underlying psychiatric disorder, refer to the psychiatric team, please. This is how we interpret the graphs.